Welcome to another episode of Med Madness. Today, we're diving into an essential topic for medical students and professionals alike: hypertensive disorders of pregnancy. These conditions are critical not only because of their impact on maternal and fetal health, but also due to their complexity and the need for precise management. In this episode, we'll explore the definitions, causes, symptoms, diagnostic methods, and treatment options for these disorders. We'll also walk through a real-life case study to illustrate these points in a clinical context. Next, let's discuss what these conditions entail. Hypertensive disorders of pregnancy encompass several conditions characterized by elevated blood pressure during pregnancy. These include chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia. Chronic hypertension is present before pregnancy or diagnosed before 20 weeks of gestation. Gestational hypertension occurs after 20 weeks of gestation without proteinuria or end organ damage. Preeclampsia, on the other hand, involves new-onset hypertension after 20 weeks of gestation, accompanied by proteinuria or signs of end organ damage. Eclampsia is characterized by the presence of seizures in a woman with preeclampsia. Chronic hypertension with superimposed preeclampsia occurs when a woman with chronic hypertension develops new-onset proteinuria or experiences a sudden worsening of blood pressure after 20 weeks of gestation. These conditions primarily arise due to underlying vascular and placental abnormalities. Risk factors include pre-existing hypertension, diabetes, obesity, advanced maternal age, and a history of preeclampsia in previous pregnancies. The pathophysiology involves abnormal placentation, leading to inadequate placental perfusion, oxidative stress, and systemic endothelial dysfunction. Moving on, let's talk about symptoms and clinical presentation. Patients with hypertensive disorders of pregnancy may present with a range of symptoms depending on the specific condition. Common symptoms include persistent headaches, visual disturbances, epigastric pain, and sudden swelling of the hands and face. Preeclampsia may also manifest with proteinuria detected via urine tests, while severe cases can present with symptoms of end organ damage such as liver enzyme abnormalities, thrombocytopenia, and renal insufficiency. Eclampsia is marked by the sudden onset of tonic-clonic seizures in a woman with preeclampsia. Next, let's explore the diagnosis of hypertensive disorders of pregnancy. Diagnosing these conditions involves regular blood pressure monitoring and urine tests to check for proteinuria. For preeclampsia, the presence of proteinuria is confirmed if the urine protein to creatinine ratio exceeds 0.3 or if there are 300 milligrams of protein in a 24-hour urine sample. Blood tests to assess liver function, renal function, and platelet count are essential for evaluating the severity of preeclampsia. Imaging techniques such as ultrasound may be used to monitor fetal growth and amniotic fluid volume, while Doppler studies can assess placental blood flow. Next, let's discuss management and treatment options. Management of hypertensive disorders of pregnancy aims to balance maternal and fetal health. For chronic hypertension, antihypertensive medications safe for pregnancy, such as labetalol or nifedipine, are commonly used. Gestational hypertension and mild preeclampsia are often managed with close monitoring, lifestyle modifications, and possible antihypertensive therapy. Severe preeclampsia requires hospitalization, with magnesium sulfate administered to prevent seizures, and corticosteroids given to enhance fetal lung maturity if preterm delivery is anticipated. Delivery is the definitive treatment for preeclampsia and eclampsia, with timing dependent on the severity of the condition and gestational age. In cases of eclampsia, immediate stabilization of the mother with magnesium sulfate and antihypertensives is crucial, followed by prompt delivery. Preventive measures include low-dose aspirin for women at high risk of preeclampsia, starting in the late first trimester, and maintaining a healthy lifestyle to manage modifiable risk factors like obesity and diabetes. Now let's consider a real-life case study to illustrate these points. A 32-year-old woman with a history of chronic hypertension presents for her first prenatal visit at 8 weeks gestation with a blood pressure of 150/95 mmHg. Despite being informed about her high blood pressure in the past, she had not been on regular medication. She is diagnosed with chronic hypertension and prescribed antihypertensive medications safe for pregnancy. At 28 weeks gestation, her blood pressure suddenly rises to 160/105 mmHg and new onset proteinuria is detected. She is diagnosed with chronic hypertension with superimposed preeclampsia. The patient is admitted for close monitoring and her anti-hypertensive regimen is adjusted. With careful management, including corticosteroids for fetal lung maturity, she undergoes a successful delivery at 34 weeks due to worsening maternal condition. To summarize, hypertensive disorders of pregnancy represent a spectrum of conditions with significant implications for both maternal and fetal health. Early diagnosis and appropriate management are vital to improving outcomes. Remember to engage with our pre- and post-podcast quizzes and Anki flashcards to reinforce your learning. Thank you for listening to Med Madness, where we strive to make complex medical topics accessible and engaging. Stay tuned for our next episode.